people are really kind of pushed away from us with copays, deductibles, confusion about their plan and complexities. And I find more and more there's a ton of medically underserved families in our communities, just a ton of them. And they're hunkered down in their basements, Googling stuff, hoping that they're okay, and they're not sure. And they're scared to go in because they're scared of their copays, deductibles, and their plan because they don't know how it's going to work. Most people are insured, but they got a $3,000 per person, $14,000 per family, deductible, and that's super, super common right now. And so they just get pushed away from us, right? And it's really frustrating. And so direct primary care comes in at like Costco membership pricing, something reasonable for the average person. I think it's average about $50 nationally per person per month, and you can see your doc as much as you want. So I think that gets rid of those barriers to the access points. Direct primary care clinics often have easy access to the doc with texting and video chat ability, and then office visits are often same day, next day availability as well. So I think it at least in my practice, I've noticed a lot of these families, they'll sign up and say, we never go to the doctor. And I'm like, okay. And then they're like, we've never been to the doctor so much, we feel bad. They go from a scarcity mindedness, like a scarcity minded mindset around healthcare, to an abundance mindset around healthcare. And honestly, that's our why as primary care physicians. Like, we want them to have an abundance of care and to access us. And, we want to answer their questions and relieve their anxieties about, is this serious or whatever. And I mean, I've been on in a bigger conglomerate where it was about 5 to 7 layers before somebody could finally contact me, and then they still failed. It's just impossible. And so to give them that direct line of communication, it just simplifies everything and makes it just distills care to its core value. It's liberating to be freed from transactional care.
Please note that the opinions and ideas shared on this podcast are those of the speakers, not the opinions of the Hoagland Surgical Medical Society or its board. While medical topics will be discussed, it is not to be taken as strict medical advice, and individual clinical judgment is warranted in applying information to patient care. It is the responsibility of the listener to judge for themselves the applicability of the information discussed with regards to their medical practice.
Welcome to the Hoagland Surgical Medical Society podcast. Today's topic will cover direct primary care. We look forward to learning about this topic as we seek the optimal way to deliver quality healthcare. My name is Jason Hoagland, pediatrician at Tanner Clinic, and I will be your host for this episode. Our guest for this episode is Dr. John Sanders. And just by way of introduction, John, give us some info about you and how you got here, and tell us about yourself.
Okay, sure. John Sanders. I'm boarded in family medicine. I was in Moab for 6 years as a country doc. I'm from a small town in Nevada. Went to UNLV for undergrad. I'm in Utah County, so I joke with people and tell them it's the opposite of BYU.
Nice.
And then I went to Florida for med school and residency, and then from there to Moab for 6 years. Full scope of family medicine out in Moab, doing babies and ER, hospital, C-sections, lots of everything. And then moved out here. My wife wanted to go to law school. She did that at BYU and tacked on an MBA. And we've been here about 5 years. And I started Voyage Direct Primary Care about maybe 6 months after we moved here.
Nice. Well, I did my FP rotation down in Monticello and just love being down there, that Monticello Blanding area. And I came to know that was full service family practice down there from what I learned. You've kind of seen the whole gamut. So what's your favorite outdoor hobby here in Utah?
So kind of maybe quirky, but I really enjoy foraging for mushrooms. I got into that a couple of years ago.
Find some good morels out there somewhere.
Springtime morels, like this has been a magical year, not for magical mushrooms, but for mushrooms in general.
They got to be careful there with how you label those.
And chanterelles up in the mountains and big Boleta sedulus, like the big red loaf mushrooms, and super yummy, good stuff.
Awesome. A fungus forager. I love it. So
throw that out there, guys. Pickleball.
Yeah, definitely. My wife would totally agree. All right. And then do you have a favorite restaurant? What's your favorite place to eat?
Oh, man. I don't know that I have any favorites, but I mean, Joe Bandito's in Springville is really great. That they have great chips and salsa and stuff. They're great.
Uh-huh. Well, I like the Jim Gaffigan approach to it. He said he's not really a foodie; he's more of an ED. So just loving to eat food. So sounds good. Well, John, how did you come to be involved with direct patient care? What was your journey?
Yeah. So, growing up in a small town, I knew everybody in my town, and good relationships with everyone, and probably more than I needed. Rural medicine was a hat that I always wanted to wear, and I enjoyed the personal touch and the time able to spend with my patients and being involved in delivering their babies and helping them through that whole process of being parents and then the helping grandmas. And I did hospice as well in Moab, and I just really love people and taking care of them. And I just, over the years of being a doc, I just constrained by the system and beat up by, inefficiencies and the gig, right?
Yeah, I'm in the middle of it. I hear you.
It gets tougher and tougher to spend time with people and really deliver the goods, right? Relationship, get to know them, do the do. So I don't know. I just a buddy of mine was in Florida doing this, and he told me about it, and I said, well, that's kind of neat. All through residency, I'd always been interested in the business of medicine, and it was always my desire to run a practice. As I understood the complexities of the business of medicine and all the coding and billing and collecting and the inefficiencies of that whole mess, I just was like, man, this has got to be a better way, right? And then my buddy told me about this model, and I thought, that's pretty neat. Let me look into that. And as I dug into it, I felt like, gosh, that really aligns with my core values of being able to deliver really good care to folks. And so, yeah, 5 years ago, startup voyage in little old Utah County, and trucking along. Yeah.
Nice. So what is direct patient care, and how is it different from concierge medicine?
Yeah, concierge medicine's been around for a long time.
Yeah.
Direct primary care has too, but it's really gained a lot of momentum in the last probably 3 to 5 years. And it's different. Concierge docs are often they charge a lot more than direct primary care docs. It's kind of DPC is kind of like the concierge medicine for the people, kind of the
Okay.
Robin Hoods out there just trying to deliver it cost effectively to everybody. Our goals are really transparent, cost effective healthcare to the masses that's transparent and good. Concierge medicine has similar goals, right? But the cost piece is just like not a thing for them, and so their prices are often 3 to 5 times more than what we charge, and their patient panels are much smaller, and then they also sometimes some of them will bill insurance on top of their concierge service, and DPC doesn't do any of that business.
Okay. So would you say the main differentiation is the cost per month to the patients and the size of the panels, or any other differentiators?
I think that's it. And then the fact that concierge clinics often bill insurance on top of their services.
I know exactly what you're saying. I'd have a family that would have a $10,000 premium payment over the year plus $10,000 deductible. So they're paying, $22,000 before they can even start to get something out of their insurance. And I think that's a huge pain point for people. How do you keep the patients who, as you said, go from the scarcity mindset from just being this deluge of patients coming in? You're having to gamble that you have a certain panel size, and they're not all going to just say, great, I can see John every day if I want to now, Dr. Sanders. How do you manage that in DPC?
Yeah, this is the most common question from any doc that's currently in the insurance game.
Mm-hmm.
Because they're just like, there's no way we could do this.
Right.
Inundated with too much stuff. It's amazing. I think it's front loaded, right? So imagine you're taking care of a family, you get everybody in for their annual visits, and you talk to them, and you spend the kids, maybe you spend 30 minutes with, and the mom you spend an hour with, the dad you spend an hour with. You get to the rub on all of them, and you get to know them really well. That's a lot of service up front, right? And then you might see them for a follow-up if you check labs and things. And then once you tuck them in, you're just there for any urgencies that pop up. So it is front loaded. Like the very beginning of that is pretty intense. You're working pretty hard, but once they're tucked in, like they're great, and they're just like family, and they just text you when they have a question about something, or they'll, hey, I've got, I'm traveling, I've got a UTI, can I,
Mm-hmm.
you can really be available for them that way. And I've got one patient that abused me, but all the rest was
Oh, I love that you're that limited in terms of challenges. That's great.
Yeah.
So Well, I guess as I think about this, John, because I'm guessing that you would really cater to people like those that have health shares and those kinds of things. Because if you talk about the pain points, if I've got a family that's already paying $10,000 a year for deductibles, are they still going to come and see you because they're paying a huge premium? So that's not a pain point that helps them. Do you find there's a certain demographic that gravitates towards DPC when you're trying to recruit a catchment population?
Yeah, this is a great question. So health shares, there's no question, health shares are a home run with a direct primary care clinic. The health shares push people into an even more scarcity minded mode sometimes, right?
Mm-hmm.
It's like per encounter, they have an initial unpaid amount. So man, if we can just get them signed up, they're loving it. They just love it. But honestly, I'd say 90% of our people they just have like any insurance plan. They'll have select health, but they're in that same boat of 3,000 per person, 10,000 per family member deductibles. And not only do they have really great, access to 30 to 60-minute visits and telehealth and video chat, but they also, we work for our people, right? We work for them.
Right.
And so we go out and find them the best pricing on labs, the best pricing on x-rays and MRI. Just today, I ordered an MRI on a gal. It's about $400, and that's pre-insurance.
Right.
She says, we got a high deductible. So, I could do it with our insurance, but it's end of the year. I don't think I'm going to hit it. What do you got for me? And I'm like, oh, we got that negotiated for you, like $400. How's that? And she's like, great. And so, with insurance, it would have cost her, thousands of dollars out of pocket. And so that just the price transparency and the fact that we're advocating for them, finding them the best pricing. We have pathology negotiated for about $70. Like a CBC is like $5, CMP is $5. I don't know. I can go on. I know all the prices in my head.
Right. Yeah, everything on your price. And I think that's wonderful. And so what about from a global, more national perspective? I've got a friend who is a CEO for Crossover Health, and they're always just looking for ways of being able to be the salvation of medicine in the United States. And so how would DPC help out on a national setting?
Man, I'd like to talk to that Crossover Health guy. That'd be really fun because they're doing some innovative stuff. They're doing some cool stuff.
Yeah.
I talked to Congressman John Curtis. He's Utah congressman, and he's on a national task force to fix healthcare. We met, I don't know, it's been a few months now. And we sat and visited about direct primary care and the pain points that it solves in the current healthcare system, and if that can be applied kind of more in a national sense. And it was fun. I was like, he has a whole bunch of people and they're all taking notes. And I was like, oh, this is kind of cool.
Cool.
Yeah, I think a lot of the principles can be applied nationally. There's a whole army of docs that are just trying to help with care and help with price transparency and affordability. And I think the average family is really in a bad situation where they've got those high deductibles and copays and confusion that's just not giving them reasonable access to good care. And so you've seen over the last 5 years, probably a 500% increase in direct primary care clinics nationally. And there's more than 2,000 now. Just 2 days ago, I was nominated onto the Direct Primary Care Alliance board. I'm just nominated. They haven't inducted me or whatever that is called. But
good luck then.
I don't know. I'm just like, I'll do it if you want me to. I'm happy to help. But it's a movement that's gaining momentum and traction because I think a lot of families are really in need of it. It's good.
Mm-hmm. Do you feel like this has an opportunity to help relieve some of the strain on the system? I mean, we're kind of spread thin. How do you feel about relieving some of the stress for the whole system?
Oh, 100%. So I just last night, gal, she texted me like it was like 7:30 at night. My daughter like fell off the monkey bars and busted her chin open, and I'm like, okay, I'll be over it. And so instead of going to the urgent care ER, like I just went to their house and put some stitches in it, washed it out, got her set up. And we probably save urgent care / ER visits routinely on a daily basis and take that strain off of those systems. During COVID, it was incredible. I mean, I was managing home hospitalized patients, putting them on oxygen, doing all the things at home, rounding on them every day. It was,
Mm-hmm.
so you have liberties and bandwidth to just really flex and fill and help out and spend the time to deploy more brain cells, not just become a throughput referral mill to the next, person on over there that has, a whole bunch of those kinds of referrals. Cause that's all,
Uh-huh.
and I think so. I think as primary care docs, we can cover a pretty large percentage of people's healthcare needs. especially if we have the bandwidth and the time to put those brain cells to work. We're well-trained folks. I think we just are time constrained. And so forced into like, okay, I gotta move you. You gotta go to the ER right now, or I can't do that.
Do you feel like, I mean, just as you talked right there, I'm picturing, if there's a heavy need, which the pandemic for me had just a massive need. Everybody needed so much more care per person. The size of my panel all of a sudden seemed like it doubled in terms of neediness. So if you've got stitches at 7:30 at night, you've got patients on oxygen, is there potential for this to become overwhelming for you instead of being something that is an improved quality of life for you?
Yeah, I would say pre-COVID, it was pretty good. Post-COVID, this we've had the never-ending flu season, like the cold and flu season
Mm.
is like there's not a let up. Like all summer long, it's been more one after the next, one after the next. And so we've had to work a little bit harder post-COVID with all the isolation and then the naivety that happens to folks' immune systems as we quarantine and all that jazz. Um,
Mm-hmm.
but yeah, I think it could be overwhelming. One of the things that we're careful about is to make sure that our practice size maintains our quality of care. And so most DPC docs try to cap their practice at some benchmark where they are still feel reasonably ethical about the level of care they're able to provide to their people. And so that's good.
Gotcha. And so is there any remuneration for you on a per encounter type situation besides the monthly fee people pay?
Yeah, I thought long and hard about that, and I could see why that line of thinking would be tempting. Most direct primary care clinics don't have that. And again, anything that pushes folks into a little bit of scarcity mode, we want to get rid of. And so a zero issue, reach out, let's do it. And when you deliver that abundance, yes, it's front loaded and it's harder, but once you deliver it, you just educate them, you work with them, and then they get it and they're like, okay. Like I
Mm-hmm.
started a YouTube channel and I have a whole bunch of common things like allergy season or like colds, and here's my recommendation. And so folks will text me and I'm like, oh, here's a video on that. And I send it out.
Right,
And
right.
oh yeah. So they're learning, right? And so as you teach your clients or your patients, then they get smarter and better. And then they don't call with every snivel or whatever.
Well, I guess that's actually leads into my next question, as far as the sustainability for patients and for doctors, is that do you see this something that would ever have to change, based on how it's gone for you already?
Um, man, I when I left Moab, I was burning hot, right? It's just like an extension of residency, 70 hours a week. I was delivering most of the babies in the hospital, and there's some older docs there that were happy to give me all the work I wanted, and so
Yeah.
I was probably a dummy and worked too hard. But I was ready to, consider other tracks. I was like, man, maybe I should just buy a Firehouse Subs franchise and run that thing.
Ride your wife's law degree and business degree. And so
Yeah,
it's
yeah. 3 years on business degree, but yes, no, yeah. And I legit like called them up. I was like, how much is a franchise? How does this work? What's the I really did like just I knew
Oh,
that the system wasn't terribly sustainable for me. I re-upped my boards not too long ago. I've been a doc for about 12 years now. And I remember at that conference just looking out at all these family docs there, national, just like thousands of family docs in this big conference center. And at that point, I had been doing DPC for about 2 years, and I'm like refreshed and full of energy, and I'm jazzed up and I'm excited, and I'm looking across the room, and they're just wrung out, man. They're just squeezed and
kind of like this. And so it's
no, but my colleagues, I was like, man, it's brutal. It's a brutal system on them as far as sustainability. You look at the med students going into family medicine, and they're just like, nope, not doing that, and so I think that leads to kind of a decline of folks of real family medicine docs or primary care pediatricians, all of those spaces, all the administrative, I call it the triple Bs, the bureaucratic box checking bullcrap. It all rolls
yeah.
downhill to the primary docs, right? And so surgeons are like, oh, go talk to your primary doc about that, have them sign that paperwork and stuff. And so we're just inundated with all this inefficiency that pulls us away from caring for people, and it's fatiguing, and it's not satisfying, it's not fulfilling, and then we're forced to see more patients per hour to keep the lights on.
Right.
You gotta have all these FTEs just to engage with the monster. And so cut all that fat out, and you can get down to the core of what we did this darn thing for, right? And
Right, right.
yeah.
Well, I guess that would again segue to the next question, is, and it's probably pretty obvious, is do you feel that the incentives are aligned for both you and for your patients?
Yeah, I love that. So incentives are like what incentivizes them to be healthy, right? And
Mm-hmm.
what incentivizes me to help them get healthy. And in direct primary care, they're paying me directly to help them, right, get healthy. And so they're
Right.
paying for something that they want to receive. And I'm trying to help them with that too, because the healthier I make them, the less they see me and the less I work. And that's sweet. And so I'm incentivized to keep them healthy and to work really hard on helping them get healthy. And they're incentivized because they're paying for it. And they're like, I need to get healthy. Like I need to make this work, and it's kind of lovely to have them, directly aligned in that relationship.
Well, that's awesome. So when I thought about doing this podcast with you, I had this hard question that I wanted to ask you and see how you can handle it. And so how do you answer the criticism that DPC or even concierge medicine removes great doctors like yourself from the caregiving pool when we already have this shortfall in physicians in the U.S.? How would you talk about that criticism?
No, I love this question. This is a great one. And thanks for bringing it up, by the way. I think we have to be critics, right? Of any kind of movement out there, we got to be, okay, there's an upside? Is there a downside? What does this look like for both parties for the future of healthcare in America? And it's not like right now I'm like sunshine and roses. It's pretty awesome, but it's not like the solution of solutions. There's more out there solution wise to the complexities of the United States healthcare system. But as far as like the core of your question, which is like, gosh, we're removing these docs, and the average family doc right now cares for probably 2 to 6,000. Last I checked was the typical census of the average family doc. Um, and that's tough. And that's right now in that system of hustle and every, 5 to 10 minutes and cranking and then quitting. Right.
Mm-hmm.
So, so
Yeah, that's a great part. You can work hard, you love your patients, but the upside is eventually you die.
yeah,
So it's
but also the system is so brutal. I'm gonna go start a Firehouse Substitute franchise, right? Like I'm done.
right.
Just not.
Get the fizz, get the yeah.
Yeah. So I think you have people making an exit out of family medicine sooner than they probably would because they love doing. I mean, they love caring for people. It's just the system upon which they ride doesn't work. I recently gave a presentation at UOMA, the Utah Osteopathic Medical Association, on this topic, and a
Mm-hmm.
lot of the old docs in the room were like, "I think I would get back into medicine in this model." And I legit think it's real. I mean, they're like in their 60s, they got gas in the tank. They just want a
Mm-hmm.
system where they can really deliver good care to people. And on the front end of that, so those guys are on the back end twilights of their career. On the budding, side of their career, I take medical students pretty much year round. I don't take 3 a year. I take one every month. And I'm just showing them the ropes. And man, I probably have a 90% retention rate into family medicine after the rotations.
Mm-hmm.
They're like,
Uh-huh.
"This is what I want to do."
Uh-huh.
and and
You
this
know,
is how I want to do it. And so I think you could really have a massive pendulum swing. Right now, the sought after ones are ortho, right? Well,
right.
ICD-10 killed ortho because you have
Yeah.
ICD-10 coding for like a left metacarpal fracture of the pinky is like brutal.
Yeah.
So take all the ICD-10 out of healthcare and you have direct primary care. We don't code anything. We don't do any of that stuff. It's like a medical mission trip. You just code a paragraph. You just write down what you did, what you thought, and why, and what the exam showed, and that's it. We're not coding anything. We're not billing anybody. We're just doing what's right for folks. And so you've got this massive pool, I think, of people actually going into primary care specialties because of this delivery system that allows them to stay true to their core value, true to their why, which is really caring for people. One of my colleagues who was going to be here tonight, who couldn't, he got a conflict thing, Ben Larson, Dr. Larson, I helped him start Orange MD a few years ago, and he's just killing it. He's great. He's up here in the North Salt Lake County area. He's in Ogden, right? Yeah, he's in Ogden. He had a comment on this question too, and one of the things he mentioned was he keeps people out of urgent cares and ERs all the time. Like he says, in the last year, he maybe has sent one person to the ER and nobody to the urgent care. And he said, if we could get those docs that are working the urgent cares and stuff to pull into the direct primary care space, and it would really relieve a ton of the pressures on that system, and they could deliver really good care. And people would be really happy with it and pretty sustainable for patients and for docs. And the sustainability is twofold. It's a sustainability on us, right, on the workload and on the burnout and all those factors, but it's sustainability on the people too. And our price points have to reflect that, right? And so what do I need per patient to make fair market value family medicine doc for caring for this many people, right? And so in
Mm-hmm.
that mathematical equation comes out to, roughly $50 a person and taking care of, 600-700 people somewhere in that ball field. Got to have some FTEs, MA back office people, front office people. You still got to have those people. So there's some overhead involved in that. And then you just go to work and it's lovely.
That's actually a wonderful answer, John. I hadn't thought about some of the things. I mean, there's this huge movement for FIRE for doctors, the financial independence and retire early. And I think if you do retain a lot more docs that still love what they do, and also we have a dearth of people going into primary care. And if you're attracting them to primary care, problem solved. And so that's a great answer. So hypothetically, not talking about me at all, John, but how would one make the transition, from my 5,000 patient panel that I have in pediatrics, traditional practice over to a DPC model?
Yeah, that's a bear, right? We're not really good at marketing, sales, going out and talking to people and telling them about this new innovative way of being and taking care of people. It's not easy. I moved here from Moab and I didn't know anybody. I didn't have family around. I didn't know anybody. And so to start that from zero was tough. I did a lot of like networking and a lot of never eat lunch alone. I'm always out talking to
Yeah.
people, and I talk to a lot of our colleagues in the community and leave cards with them and talk to people, and at the kids' soccer games, I'm like, hey, I got a card. You're
Good for you.
as docs, we're not business people. We're not good at that whole marketing sales thing. So that's part of my mission too, because docs are really good at medicine. Like we're good at medicine. But the other parts of that equation are sometimes really tricky for every doc, right? And so I'm trying to create systems that allow these docs an easy segue into this space and to grow a practice at a reasonable clip without a ton of their, are you marketable? Are you going to every football game? Are you handing your cards out there? Um,
Mm-hmm.
but to just try to gain more and more momentum. And I think that as this movement continues to gain Google ability, so just traction
Mm-hmm.
in the social like spaces of everything, and it is gaining traction. When I started, there was Zippo, there was SEO ability of direct primary care was like negative 20. It was dumb.
Wow.
And so it was really just putting it on my shoulders and pioneering that thing forward and talking to everybody. And so it was really challenging. I brought a doc on about 2 years ago, super great rural doc, moved here from Tillamook, Oregon, because Oregon got really crazy with COVID thing. He's like a refugee. And so he came out here and he's been great. And I've got, a lot of like KSL stuff and all this other stuff. And he's grown a beautiful practice in a couple of years. And there is definitely a ramp up, right? And there's some risk with that ramp up where I made negative money for, months and
Yeah.
months, and that was tough. And
Yeah.
I've got a wife in law school and 4 kids, and negative money. It was awesome. But you got to moonlight, like Dr. Larson is moonlighting and doing some stuff, pulling some shifts in the urgent cares and stuff to make it work. And he believes in the mission and he's working really hard to grow a practice. And once you grow a practice, the attrition rate is very low. You'll have some, over the years, but usually it just keeps growing by word of mouth after that. And there is a critical mass to that growth that then you just say, okay, I'm capped and not accepting new
Mm-hmm.
patients, but I'll let you know if my patient panel opens up again. And it's pretty sweet. But that does take time and there is some sweat in that.
Well, awesome, John. Thanks so much for all the insight. I think it's a beautiful model, and I've got some good friends that are in that space of, like you said, being transformational, and I think that there's kind of pioneers like you that are able to be vanguards for the rest of us that feel comfortable in our little stable models. But I'm hoping this can get out to people, and we can have a lot of people become some nice disciples for the DPC going forward. So, any last comments or words? And so, give me
Yeah,
the final word.
yeah, I love your disciple thing. That's funny. It really is a grassroots movement by docs and people, right? We serve probably 17 little companies in our community too. And it's a win-win for the small to medium, large companies. There's massive upsides to that. There's a whole nother conversation around the sustainability for business and how DPC can fit in. We really just talked about the benefits to the individual families and clients in today's podcast, but No, this was really great. I appreciate your thoughtful questions and stuff. It's just a movement that hopefully will continue to roll forward and provide good care to the communities.
Well, thank you for your cheerleading and your leadership.